I am absolutely thrilled to be jumping into this with you today. As requested, this is the MCQ discussion video based on today's provided topics in obstetrics and gynecology. We've got a really fantastic set of high-yield clinical scenarios to work through, and I'm going to guide you through every single detail so you can just lock this knowledge right in.
All right, let's dive in. Just to give you a quick roadmap under our MCQ discussion heading today, we're covering 5 main topics. We've got managing gonadal dysgenesis, evaluating enzyme deficiencies, classifying amenorrhea causes, diagnosing Turner syndrome, and understanding Swyer syndrome. And of course, we'll wrap it all up with a high-yield summary review.
Okay, let's move right into our first clinical challenge. Section 1 is all about managing primary amenorrhea in a patient with a pretty specific complex karyotype. This is a classic board-style question that really tests your understanding of gonadal risk.
Take a second and read the entire scenario and the options up on the screen. We have an 18-year-old girl presenting with primary amenorrhea, no breast development, and Prader 3 genitalia. Her FSH is raised. Now, crucially, her karyotype reveals a 45XO/46XY mosaicism, and her ultrasound shows Müllerian structures but poorly visualized gonads. So what's our next line of management here? Is it A, vaginoplasty, B, bilateral gonadectomy, C, HRT to induce puberty, or D, clitoroplasty? Go ahead and lock in your answer.
Okay, the correct answer is option B, bilateral gonadectomy. Let's break down exactly why. This patient has mosaic Turner syndrome. Because of those 2 different cell lines, on one side she has a streak ovary from the 45XO line, but on the other side she actually has a dysgenetic testis from the 46XY line. Now, here is the absolute golden rule. A pure streak ovary and 45XO, no malignancy risk. However, the presence of a 46XY dysgenetic testis drastically increases the chances of terrible malignancies like gonadoblastoma or dysgerminoma. Because of that risk, those gonads literally have to come out immediately.
Let's look at why the other options fall short. Option A, vaginoplasty, that's typically the management for Müllerian agenesis, usually done right around the time the patient becomes sexually active. So it's not relevant here since she already has a uterus. Option D, clitoropathy, is a later surgical step we'd see in conditions like congenital adrenal hyperplasia. And what about option C, hormone replacement therapy? Well, yes, she's definitely going to need estrogen for breast development and lifelong HRT eventually, but it is absolutely not the immediate next step. Your #1 life-saving priority is removing that malignant potential via gonadectomy.
Brilliant! Let's shift gears to Section 2 and look at how specific enzyme deficiencies completely alter sexual development, giving us some pretty unexpected clinical presentations.
All right, read through the second MCQ with me. An 18-year-old girl presents with amenorrhea. On examination, she has normal female genitalia and normal breast development. Her tests reveal a 5-alpha reductase deficiency. So what could be the probable overarching diagnosis? Is it A, concealed sex, B, true hermaphroditism, C, female pseudohermaphroditism, or D, male pseudohermaphroditism?
If you picked option D, male pseudohermaphroditism, you hit the nail on the head. Let's define this concept so it really sticks. Male pseudohermaphroditism is a broad diagnostic category for individuals who actually have a 46XY karyotype, meaning genetically they are male, but they present with female or ambiguous external genitalia. In this specific case of a 5-alpha reductase deficiency, the body literally cannot convert testosterone into the much more potent DHT, or dihydrotestosterone. Without that DHT, the male external genitalia just fail to masculinize properly in utero, so the child is assigned female at birth, but presents later with primary amenorrhea.
This beautifully illustrates why the other options are just plain wrong. Option C, female pseudohermaphroditis, typically describes a 46XX genetic female who becomes virilized. That's the most common presentation of congenital adrenal hyperplasia, which is definitely not our case here. Option B, true hermaphroditis, which we actually call ovotestis nowadays, requires the presence of both ovarian and testicular tissue in the same person, which doesn't happen with a simple enzyme defect like this. And hey, quick pro tip, when comparing 5-alpha reductase deficiency to complete androgen insensitivity syndrome, notice the key difference. Patients with complete AIS actually have well-developed breasts because their testosterone aromatizes into estrogen, but patients with 5-alpha reductase deficiency, they typically present with absent breasts.
Okay, moving right along to Section 3. For our third question, we're going to test your ability to categorize the different causes of amenorrhea. This is all about knowing what happens before menses ever start
versus after.
Let's look at this challenge. Which of the following is not a cause of secondary amenorrhea? Your options are A. Turner's mosaic, B. Kalman syndrome, C. Sheehan syndrome, or D. Asherman syndrome. Now watch the wording carefully. We are looking for the condition that exclusively presents as primary amenorrhea.
The correct choice here is option B, Kalman syndrome. Let's dive into the why. Kalman syndrome is your classic textbook cause of primary amenorrhea where the uterus is actually present. It's defined as hypogonadotropic hypogonadism. What that means is both FSH and LH are really low because the hypothalamus completely fails to secrete GnRH. It involves a defect in the KAL1 gene and is famously associated with anosmia, meaning these patients literally can't smell. Because that hormonal cascade never even kicks off, puberty just never starts. Breast and pubic hair are absent, and menses never begin. Because of that, it absolutely cannot be a cause of secondary amenorrhea. Let's look at how this helps us understand the incorrect options. Secondary amenorrhea simply means menses stop after previously occurring normally. Option C, Sheehan syndrome, is postpartum pituitary necrosis. Option D, Asherman syndrome, is intrauterine adhesions. Both of these are acquired later in life, making them classic secondary causes. But what about option A, Turner's mosaic? Well, while pure 45XO Turners causes primary amenorrhea, mosaic Turners, the ones with some 46XX cell lines mixed in, can occasionally undergo puberty, menstruate for a bit, and then experience premature ovarian failure. That presents as secondary amenorrhea. So, Kalman is literally the only one that strictly fits the not secondary criteria. Excellent job so far, guys. Let's tackle our fourth MCQ in Section 4. This one requires some classic pattern recognition of physical examination and hormonal findings. Let's see if you can spot the triad. Listen to this setup. A 16-year-old presents with absent menses. Examination shows widely spaced nipples, a webbed neck, and Tanner grade 1 breast development. Her ultrasound shows streak ovaries. Investigations reveal raised FSH, raised LH, and reduced estradiol. What's the diagnosis? Is it A, Turner syndrome, B, Kalman syndrome, C, androgen insensitivity syndrome, or D, MRKH syndrome? The correct diagnosis is unequivocally option A, Turner syndrome. This patient perfectly matches the classic triad. First, she has primary amenorrhea. Second, the ultrasound confirms streak ovaries. Now, because those ovaries are completely non-functional, there's no estrogen to provide negative feedback to the brain. That leads to our third finding, hypergonadotropic hypogonadism. Basically, the pituitary is screaming at the ovaries to work, giving us massive levels of FSH and LH. Add in those physical traits like a webbed neck and widely spaced nipples on a shield chest, and you have a textbook 45XO karyotype presentation. Ruling out the other options is actually pretty straightforward here, mostly based on hormone levels. Option B, Kalman syndrome, we just learned that features low FSH and LH, not raised. Option C, androgen insensitivity syndrome, that would present with a 46XY karyotype, an absent uterus, and completely normal, well-developed breasts, definitely not Tanner stage 1. Finally, option D, MRK or Mullerian agenesis, features an absent uterus with perfectly normal functioning ovaries. That means their FSH, LH, and estrogen levels would be completely normal.
You are doing great. We are on to our final clinical case in Section 5. We're going to explore a really fascinating presentation where an individual's genetic sex and their outward phenotypic appearance diverge completely. Analyze this final MCQ with me. A 20-year-old girl presents with primary amenorrhea. On examination, breasts are poorly developed, but a vagina is present. Ultrasound reveals a normal uterus, but the gonads are completely undetected. Further evaluation shows a surprising 46XY karyotype. What is the most probable diagnosis here? A, androgen insensitivity syndrome, B, Turner syndrome, C, true hermaphrodite, or D, Swyer syndrome? The correct answer here is option D, Swyer syndrome, which is also known as pure gonadal dysgenesis. Let's explain this in brief because it's super interesting. In Swyer syndrome, you have a 46XY karyotype, often due to a point mutation in the SRY gene. This causes the testes to fail to develop properly. They become dysgenetic. Because they're essentially non-functioning, they produce absolutely no anti-Mullerian hormone, or AMH, and no testosterone. So without AMH, the Mullerian ducts are free to grow, meaning the patient develops a perfectly normal uterus. And without testosterone, the external genitalia default to female. But since there are no functioning ovaries to produce estrogen, puberty just doesn't happen, and breasts remain poorly developed. Contrasting Swires with the other options clearly shows why they're wrong. Why isn't it option A, complete androgen insensitivity syndrome? Because while AIS is also 46XY, the testes actually do function and produce AMH, meaning AIS patients have an absent uterus. Furthermore, AIS patients have well-developed breasts, unlike our patient here. Option B, Turner syndrome, is ruled out immediately by that 46XY karyotype. Turner's is always 45XO. And option C, true hermaphrodite, would feature both ovarian and testicular tissues, not entirely undetected dysgenetic gonads.
Wow, okay, that was a lot of great clinical pathology. Now that we've broken down all 5 complex cases and really explained the underlying mechanisms, let's step back and consolidate all these high-yield topics into a quick summary review.
I want you to remember these absolute clinical rules for your exams. If you have ambiguous genitalia with impalpable gonads, think XX ovary, usually CAH. But if those gonads are palpable, think XY testis. Remember that dysgenic testes, like the ones seen in Swires or mosaic Turners, always have to come out immediately due to that extremely high risk of gonadoblastoma or dysgerminoma. Conversely, pure streak ovaries in 45XO Turners, no malignancy risk. Finally, always look for the uterus. An absent uterus usually points to AIS or Müllerian agenesis, but its presence alongside a 46XY karyotype, that strongly suggests Swires. And remember, hormonal profiles like a raised FSH cleanly separate primary gonadal failure from central defects like Kalman. This structured breakdown should give you a huge advantage on your exams and help you easily identify the correct diagnosis while confidently ruling out all those tricky distractors. The next time you see a complex karyotype, I want you to ask yourself, is the risk of malignancy hiding in plain sight? Thank you so much for joining me today. Do like, share, and subscribe channel The Learning Medico. Until next time, keep studying hard.